You are listening to the Only Healthcare podcast. We are here to inform you on the whys, hows, and whats of healthcare. Hosted by industry leaders Michael Navin and Dr. Randy Vogenberg, here to discuss why are costs and risks so high and who should be held accountable? How will technological advancements merge with the quality of care? And when does the public get to gain access to these advanced medical treatments? Listen in as Michael and Randy seek to answer these industry concerns for the public and all stakeholders involved.
Welcome all. This podcast is really meant to dive deep into the world of pharmaceutical therapies and really focus on how that impacts the U.S. healthcare system. Our goal is to not just inform and educate, but to really be able to explain what's happening in the market and how the market is changing like never before, and hopefully giving us an audience to be able to have conversations down the road about how we can make impact and make a change in the marketplace. And we want to ultimately be a place where we can be for change and change in the right direction. My name is Michael Navin, and I'm joined by Randy Vogenberg. Briefly about me, I spent 27 years in the pharmaceutical world on the commercial side, both sales and brand marketing. I own my own agency that we served many pharmaceutical companies over the last 20 plus years in launching their products and ultimately getting access to those products. So we created a platform for people that when new drugs came to the marketplace, the average person was able to afford some of these advanced treatments. So we're pretty proud to know that we've done that for many years. And we have a lot of insight into how those things are done and how they'll be done in the future. Randy?
Thanks, Mike. My background is starting out as a pharmacist, and I've had the opportunity to work in all areas of the healthcare delivery system, both at the community, hospital, and also at the governmental level, working in how healthcare is not only delivered, but some of the policy issues, and then eventually moved into the employer space through my doctorate degree in healthcare administration. So I've been working in the employer plan sponsors and self-insured marketplace for the last 25 years. Seen a lot of change. There's a lot more change coming. And to provide some insights and conversation around, so what are these changes? What are we seeing? Potentially having different guests in as well to provide more background and ideas around action that can be taken. So it's not just about the problems, it's also about the solution.
So yeah, and I think so today we're going to get right into that and talk about really how are drugs and pharmaceuticals distributed across the U.S. Specifically, a lot of people wonder how are drugs paid for? And it's a very interesting dynamic. It spans all the way from the manufacturer making a product through the development of that product, all the way through how middlemen are being compensated for the distribution, ultimately back to the patient. Just want to talk a little bit about that. And really what we're finding in the changing marketplace is that transparency is paramount, and transparency not just to the patient who's sometimes paying and sometimes not, transparency to the employer or the health plan who is also paying for that medicine, and really who's on the hook. So Randy, I want to talk a little bit about this impact of what's recently happened with some lawsuits, J&J, and really how the employer sponsor of the healthcare is now ultimately on the hook.
Sure. There's been a lot of change, as we've been alluding to, that will continue to happen in how the different therapies are being distributed in the United States. And we're going to use the word therapies a lot more than just pharmaceuticals because of what we're seeing in the research and development pipeline, or R&D pipeline. Some 20 plus years ago, when I wrote my first pharmacy benefits book with the International Foundation of Employee Benefit Plans, we were talking about non-specialty drugs at that point and looking at access and management within just the pharmacy benefit. A subsequent book that just came out last year began to focus more around integrating pharmacy benefits for specialty pharmaceuticals, again, dealing with access and management. And to your point, Mike, understanding what really is going on in that marketplace. What are the different players doing or not doing? How's that affecting what has happened? And particularly under ERISA, the Employee Retirement Income Security Act, where the self-funded plans really get their authority to do what they do as a plan sponsor. There's a lot of important implications, and that's the lawsuits that you're now referring to. So what's happened, not just with the Johnson & Johnson lawsuit as an employer, which makes it even more interesting under the ERISA statute, but also in March of this year, there was a Office of Inspector General report through the Office of Personnel looking at the results of an audit that they conducted. Again, even though it was a government agency, a lot of the same rules apply for benefit management, and that includes the requirement for auditing. And so this whole issue around what PBMs do, what they don't do, how that affects distribution now comes into a much greater focus.
So let me throw out a couple examples. So one is you have a product like, let's say, Lipitor, which has been on the market for many years. It's generic. You may have a benefit that covers generics. And then let's take some more novel cell and gene therapy. Let's use Vogenberg as an example, as a specialty product. How does it work? Given those two products, how is it working today when it comes down to the reimbursement?
The basic criteria that we look at in the current marketplace is it covered under a medical benefit or is it covered under a pharmacy benefit? That's the first question. The second question related to that is who is ultimately responsible for either one of those two benefits? So is it a self-funded plan that an employer has in place, which could be a municipality, it could be a government entity, as well as medium-sized business. J&J is an example of a large jumbo style account. So to try to understand the framework, so what rules really apply and how would coverage occur? Traditionally, it's always been if somebody has to have a intramuscular injection or an infusion, that's medical benefit. If it's basically an oral pill or it could be a self-injectable, like what we're seeing with the GLP-1s, where a lot of them are self-injected, that would be under the pharmacy benefit. And traditionally, nobody really paid a lot of attention to pharmaceuticals and other drug therapies under the medical benefit because there are other higher costs. And now a lot of that is shifting. That's part of this evolution that we're living through right now in the post-pandemic era. We now have to look at where all of a sudden you're seeing a low volume product like a GLP-1, Vogenberg being one of those, and there are several others, that all of a sudden is shooting through the roof in terms of utilization. So you're seeing larger numbers and with that larger costs to the plan. And a lot of that is showing up in the pharmacy benefit. That's typically where these products are being reimbursed. And so the traditional way in which you would pay these claims is being called into question because of this significant shift. And the methodology that's being used by whoever's managing that pharmacy benefit, because typically that's outsourced to a benefit administrator. This is where all the problems begin. And that was part of the issue that was identified by this OIG report just a few weeks ago of a major governmental plan and how reimbursement was not really transparent. So even though the administrator paid the claims, the plan sponsor covered those claims, there was a lot of hidden either rebates or discounts that were not fully disclosed, were not paid appropriately. And therefore, the plan sponsor was ultimately paying more than they needed to be paying. And that's a very common finding today. So on the back end of all this, the patient as a consumer and a member of a plan doesn't see a lot of this going on, but it affects the plan sponsor dramatically, particularly when you add in the fact that now these costs have doubled or tripled in a typical plan. So there's a lot of pressure financially on these plan sponsors, particularly if they're self-funded, because it affects their bottom line profitability, because this hits the balance sheet. So there's a lot of interest in this. And then you layer in the other aspects around ERISA, which requires a fiduciary responsibility, raises more red flags around. So what is that plan sponsor really doing? So that's something that begins to come into play when we start looking at reimbursement.
And so how does that get checked? How is there checks and balances? It's interesting how you phrased it, because if you're running a company, you do a financial audit on your business to see, are you viably sound, and what are the maybe areas you don't see overall in your business? But I wonder if they're doing audits on healthcare and the healthcare spend, or maybe there are some services or solutions that are out there that these employer sponsors haven't been able to take advantage of.
Yeah, that brings up another whole can of worms in terms of how employers contract for their benefits. Typically, they're working with a broker or perhaps a consultant or both in the selection process of who they're using. And that's where the exposure starts is, so what are you doing in the selection of a benefit manager to begin with, and who's involved in that? And is somebody either gaining or losing just in the contract process to begin with? So that's an ERISA issue as well that was brought up in that J&J lawsuit. It's important to really look back at the very beginning of this whole thing. And then once the contract's in place, you've selected somebody. So what's happening in that contract? So as you point out with auditing, after you've been running the program for 6 months or a year, how are you adjudicating the rebates? And how do you make sure that you got what you were promised in terms of the contract? So were rebates received? Was it the adequate amount of rebate dollars? What about the formulary compliance? Because that affects what you get on rebates as well. What is the pricing methodology, and is that being followed as well? So are you using AWP minus 12, AWP minus 87? What's the formula that's being used in each of these claims being adjudicated? And so these are all the things that you want to be looking at from a plan sponsor perspective, whether you are just contracting out the risk and you're using a traditional health insurance plan and you're buying coverage. You still have a responsibility to make sure that what you purchase is not a pig in a poke. But it's even a higher standard if you're self-insured and you're responsible as a plan sponsor under ERISA. So compliance to what you've contracted for is very important, and members have a say in this, particularly in the self-funded side. And that was the J&J lawsuit, was brought by members of the plan. In the case of the OIG report in the Office of Personnel, they were representing the government in the contracting, and they were looking at compliance to the contractual terms. So a lot of this can blow back onto not only the PBM as the benefit manager, but also to everybody they do business with, including manufacturers.
But manufacturers don't have a fiduciary responsibility. It really falls between the planter, the TPA, and the employer to ensure that contract compliance is there, as well as the right rebate stream is being paid out? Or is it still the employer who's ultimately in charge of that?
Well, the employer is the first line. They have the biggest skin in the game, so to speak. But we're not really sure where this is all going to go. This is all new territory. A lot of this hasn't been tested before. So there are lots of different lines of thinking around this. But the problems around the rebates, the discounts, the accumulator programs that manufacturers are involved with, all these other ways in which access has been manipulated kind of, in a way, trap manufacturers in a scenario that may not be good for them. But we don't know that. It has been tested in a court of law. But this is where this is headed at this point. So it's another risk factor that you have to take a look at when you're getting involved in contracts with third parties like a PBM around, how are you making decisions? How is your product being placed? It's not just a straight quid pro quo, which most lawyers always talk about. This raises a bunch of other questions that haven't really been asked before. And so the tendency that we're hearing more and more in conversations, there's going to be more lawsuits, and there's going to be a lot more testing of these concepts to see where the risk really lies, and are there multiple parties that could be litigated against.
Unfortunately. Yeah, that's not an area we want to see. is lawsuits.
Exactly. Right.
But I guess the other thing is, to add to what you're saying, I think as the lens that I come from is, I see how consumers are now taking more of an active role in their healthcare, not just being able to understand and ask the right questions for their doctors, but to be able to access information. There's companies like GoodRx that came out, and Mark Cuban Cost Plus Drug, and Single Care. There's ways that patients can see what drugs cost, whether they're generics or brands, exclusive of their insurance benefit that they have. Do you see those companies having an impact at all? And do you see the consumer landscape starting to change because of those organizations?
Yeah, the highest exposure has always been the consumer in a pharmacy. So the member of a plan that goes into a pharmacy to get the prescription filled. I mean, it's so commonplace. And so that's where the exposure has been in the pharmacy benefit. That's going to continue. That's not going to go away. But to your point, the common concern shared by the patient as a consumer, along with the plan sponsor, who's the employer typically, is this issue of, well, what really is the cost? What is the net cost? What really am I going to be responsible for? And is it a fudge number or loosey-goosey number, or is it something that we really can wrap our arms around? And that's where this whole transparency debate has been around, including conversations in Congress and the testimonies that are being taken as we speak, actually. So this whole issue of net costs and where rebates come in and all the other things that go on and benefits are being examined much more closely than they ever have been. And to a certain extent, perception is reality. That's the game that we see coming out of Washington, is the perception that there's got to be something bad here. And that's part of the trap, not only for the employer to be careful about, but also for anybody in the distribution chain, whether it's a pharmacy in the community or in a hospital setting, because 340B comes into play on this, but also the manufacturers, because they're involved in all these contracts. So everybody's got some exposure in this area right now, since we're not really utilizing net cost as a primary way in which we operate. The second aspect of this is with the newer therapies, the novel therapies that you referred to, that's a game changer. And that's the whole argument that has been made in recent years around, we really need to look at integrating benefits more effectively, because that's created another whole problem for the consumer. Again, consumers looking for transparency, to where we haven't really had a lot on the medical benefit. There has been some legislation in the last few years that has begun to address that. It has not worked very well. The Hospital Transparency Act, as an example, and others. That's going to continue. That's not going to go away either. So we're going to see it both on the medical side, just as we have seen it in the past around the pharmacy benefit alone.
Thanks, everyone, for watching and spending time listening to us. Just to close out, I have a couple things wanted to throw out there. One is it's been a great pleasure to have our first conversation about this and really start to dive in a little deeper. Join us next time, because we really want to make sure we're continuing on the conversation. We want to hear from you to be able to give feedback around other topics we can discuss in the overall concept of healthcare uncovered. But I will leave with, I do have one question that we're going to lead to that goes into the next episode, which is we really want to dive into what coverage means and reimbursement means. So the real basic question is, Randy, is there a difference between coverage and reimbursement?
Yeah, absolutely. And this first episode, we covered a lot of basic content, covered a lot of where we see change happening. And we're going to be seeing a lot more just around that difference between what really is coverage, how's that tied to the health benefits that we have, either medical or pharmacy, and then what's actually being reimbursed and who's putting money out of pocket. So that's going to be fun to explore.